I'm Nancy Swigert. I work at Baptist Health Lexington, a community-based hospital in Kentucky, and currently work in the Outcomes Department as Process Excellence Coordinator. And I want to talk with you today about data, which I love, finding the right data to improve practice and to demonstrate your value. These are my disclosures. I received financial compensation from ASHA for this presentation. And non-financial is that I've been a volunteer for ASHA for more decades than I'd like to admit, and co-chaired the task force on treatment outcomes in the 90s. And we're going to be talking a lot about outcomes data today. So why would we talk about data? Well, I looked to pull some quotes because lots of people talk about the importance of data. So this one is from Deming, who is a business guru. And Deming said, "In God we trust, all others must bring data." And I'm sure we've all heard that quote. And then this is from Peter Drucker, also a management guru. And he said that what gets measured gets managed. And that's where we have to start if we're going to change anything. For a more recent quote from Carly Fiorina, she said, "The goal is to turn data into information and information into insight." And this quote from Charles Babbage, I looked up who he was. He's an English polymath and is credited with inventing the modern computer. And because we all make mistakes, I love this quote, "Errors using inadequate data are much less than those using no data at all. So at least we won't make mistakes that are quite as bad if we use data." This is a Sherlock Holmes quote. "It's a capital mistake to theorize before one has data. We do it all the time, however, think we know the answers before we really have data." And then how about this simple one? I just love data. So one of the challenges, of course, is knowing what kind of data you need to solve whatever problem you're facing, because different problems require very different kinds of data to solve. Sometimes we don't have the data, but many times we do. So where would we look for data? Where would we even begin if we are presented with a problem that we think data can help us answer? So let me clarify some terms about data. Efficacy. Now, efficacy is the extent to which you get the outcome that you want. You get the specific intervention works, the procedure works, the service works, but this is under an ideal condition. So efficacy data is the kind of data we read when we read an article in a journal. So it's in a controlled lab environment. Now, effectiveness is very similar. It's the extent to which your planned outcome, what you want to happen, your goals, your treatment objectives, it's the extent to which you reach those based on whatever activity or strategy or intervention that you put in place that you intended to have an outcome and you got it. Now, the big difference is this is under ordinary circumstances. This is not a lab. It's not a scientific experiment. It's everyday life. So really, efficacy and effectiveness are pretty much the same thing. The difference is the setting in which it occurs. So again, efficacy in a very controlled environment. Effectiveness, we're talking about real-world environment. Then you have efficiency. Now, this is an economic term, but one in healthcare that we use a lot. So efficiency is really what do you get out of it for what you put in. So it's the ratio of your output from all the inputs that you put in. So how much bang for your buck, for example. So what are you getting out of it? What is your outcome compared to everything it took to get it? What resources it took, what time it took, what effort it took. So you could apply this term to both efficacy and the effectiveness. So you could have a lab experiment that you performed and found that you had something that was very efficacious. It could be efficient or it could be not efficient. You could also have a study where you looked at something's effectiveness, but you might have good effectiveness that was either efficient or not efficient. Obviously, we would like it to be efficient and effective. Then outcome measures. Now, outcome measures are tools that measure baseline performance. Then they're also typically used throughout the course of the treatment or intervention, used again at the end, and we measure what the outcome was, how the person performs on those measures compared to how they were at baseline. You know, basically that's what we do every time we write a treatment plan. We write goals and objectives, long and short-term goals, and at the end we see whether or not the client met them. That's an outcome measure on an individual client. So this is a real-world environment. It is not a controlled experiment. Therefore, you cannot claim that what you did with the client caused that outcome, resulted in that outcome. What you can say is that the outcome occurred during the course of time that you were seeing the client. I also want to throw in another term, and we'll mention it briefly later in the talk, and that's patient-reported outcomes, or you hear them called PROs. So this is how the National Quality Forum defined PROs. It's any report of the status of a patient's or person's health condition, their health behavior, or their experience with health care that comes directly from them. It can't come from the clinician or be interpreted by anybody else. Now, as you can imagine, that's a bit challenging for individuals that we see who have communication disorders and or pediatrics that we see, because they can't directly tell us about their experience with our services. So PRO tools are very important these days in healthcare and in looking at whether healthcare is effective, but they're a bit challenging to use in certain situations with communication disorders. Okay, one more comparison, and let's talk about the difference in outcome measures and process measures. So I've talked about outcome measures, and what they are doing is looking at the end result. Did we set an outcome, set a goal we wanted to reach, and did we get there? So for example, do children at our clinic communicate more effectively at the end of their intervention than they did at the beginning? That's an outcome measure. Process measure looks at the steps of things. So process measure looks at, are there certain things that should be done, and did we do them? So did we give the parent the case history handout? Did we provide educational materials? Did we use a specific method like teach back when we are providing education to the spouse or the loved one? So did we do the things we said we would do? That's simply it. This is on the list to do. We did this. So that is a process measure as opposed to an outcome measure. So now I want to give you a quick primer on the ASHA National Outcomes Measurement System, and this is near and dear to my heart because I worked on it for years in the 90s when it first began. And that's when the challenge first presented itself. So in the 90s, there began to be lots of demands, as there are now, from outside persons to ask us basically, why should we pay for speech-language pathology services? Are you guys worth it? What is it that can prove that this is a valuable service? We looked at the existing outcome tools that were in existence at the time. The FIM is a perfect example. And they just don't capture change in terms of communication or swallowing. And if you've used any of those tools, you know that. So that was the problem. So the response from ASHA was to develop and manage a valid and reliable source of outcomes data for speech-language pathology. And we wanted that data to be meaningful to clinical, but also to non-clinical audiences. And we wanted to capture benchmarking data, because that way you can compare the client's performance against a benchmark, not just against themselves. And we wanted it to go across the continuum of care. We also wanted it to meet the needs of lots of different audiences who wanted the data, and again, across the continuum of care, to really help people manage their programs and change the way we provide services. And the last item is to provide a basis for us to change practice patterns, because that's really what it's all about, is we want to do better what we do and change practice patterns. So this kind of data that we're looking at in NAHMS can do many things. It can be used to analyze and improve the way we provide services, as I mentioned. But it can also provide answers for clients and their families about expected outcome. And I bet you've done the same thing I've done hundreds of times. When a loved one asks, how will my father, my brother, my spouse do? We say things like, well, it all depends on how much he works in therapy and how much you support him, and based on my experience. And those are all valuable pieces of information, but wouldn't it be nice to be able to say, hey, based on looking at thousands of clients who presented problems similar to your father, let's say, this is what we can predict. So that's a powerful use of outcomes data. We can also use the data to provide information to administrators and third-party payers about the value of our services. And you can benchmark your facility's performance against your system. Most of us work at a facility that's part of a larger system. And then you can also benchmark it against national data. And certainly my experience has been that regulatory agencies love the fact that you are benchmarking against an outside, reliable piece of information. It's fine to show how you've worked to improve your own program compared to how your program was, for example, the year before, but it's much more powerful to be able to say, let me show you this compared to other facilities and national data. So then you wonder, well, what kind of questions could I maybe get answers to if I look at outcomes data? So, and if you know any of these answers already, we just, skip fast forward, but most of us don't have the answers to these questions. So, for example, on average, how many sessions are reported to be needed to treat an adult with aphasia or dysphagia or name any other disorder? On average, how much gain will a patient demonstrate during a given time period with a specific treatment setting? So, for example, over a 6-week period in a home health setting. Or how many sessions will it usually take to get a patient off of tube feeding? Or do patients progress faster with more intense treatment? Those are really good examples of the kinds of questions that outcomes data can answer. So let's take a little snapshot of NOMS so that we know what that is. I bet many of you already participate in NOMS, but for those of you who don't, let me just share a little information. It's a web-based data collection and reporting tool. It's for use by ASHA-certified clinicians who are providing services in healthcare settings. So that's kind of an overview of what NOMS is. There are 2 components. There's an adult healthcare component, and there's a pre-K, a 3 to 5 year component. And there's great participation in NOMS. So if we look at only the adult component, there are 10,000 participating speech-language pathologists who are contributing data from their facility to the national database. That's 950,000 cases that have been submitted. Now, if you combine that and look at the adult component and the pre-K component combined, there are 11,500 participating speech-language pathologists. That's over a million cases that have been submitted. That's a lot of powerful data. It's pretty easy to use. We've used it at our facility since its inception. You collect the data on your client at the beginning of treatment, things like demographics, the diagnostic information, their functional status, and then at the end of treatment, and you then provide information on, for example, the service delivery model and the functional status again. And this is an example of some of the demographics that are collected on the patient characteristics like their diagnosis and their gender and their age. We also collect service delivery characteristics like what is the current treatment setting, and of course the value of that is that you can compare your data to national data in the same treatment setting. We wouldn't want to look at data, for example, from skilled nursing and compare it to acute care. Those are very different. We also want to know what is the setting prior to the client coming to you. Did they get any previous services from speech-language pathology? What's the frequency and intensity of the services you provide? And what about post-treatment? When they're finished at your facility, are they going to get services elsewhere? What is the post-treatment setting? So reporting functional status is really built on outcome measurement scales. So they're called functional communication measures, or FCMs. So these are disorder-specific 7-point scales. And on each of the scales, 1 is the most impaired and 7 is the most functional. So that's how the scale is built. And it describes changes in functional communication or swallowing, whatever the area is you're working on over time. The clinician selects which ones of those FCMs to rate. You don't rate them all, you rate the ones that you're going to address in therapy with your client. And it's not dependent on any standardized tests, although of course we use standardized tests with our clients, but you don't have to have performed one specific standardized test, for example, in order to rate a specific FCM. So this slide is showing you all the different areas, and this is on the adult component, for which there is a functional communication measure. So for example, you have attention, memory, motor speech, voice, swallowing, spoken language comprehension. So you would select the areas that you are going to address with your client and you would rate those. Now, NOMS has been upgraded and made lots of improvements over the last several years, and one of the really nice features for those of you who see patients with Medicare Part B, you're very familiar with what we call G-codes, and that is having to report the functional status of patients at periodic times, and this is reported to CMS. So, to make your life easier, ASHA NOMS was modified so that when you score an FCM, it will automatically give you what the G-code and the severity modifier are for that area. Pretty sweet. And they correspond really nicely, and you can use them at admission, you can use them at those interim points, for example, at the 10th day, that you have to report G-codes, and then also at discharge. Now, here's another really cool feature. It has a goal-setting feature. So when you participate in NOMS, you have access to real-time, real-time, any cases that have been submitted, benchmarking data. So that you can, let's imagine again the conversation with the daughter of an adult patient you're seeing who wants to know, well, what are we going to, what's Dad going to work on? You can use the severity information that you've inputted into NOMS, get real-time data, and look at, for example, other patients that age with that disorder and with that area of impairment like motor speech and give a good prediction and help set a goal. You can also pick data out of patient characteristics, so severity level or, as we said, the diagnostic category, because that helps you with goal setting. Because as we know, not every, for example, 72-year-old with a stroke with motor speech is the same. They're very different. There's also flexible data reporting. So there's this new interim reporting form that allows NOMS participants to collect data, as we said, at those very specified times for Medicare. And then you can get a customized report for your facility, and then you can compare it as well to the national. You can put in other data points as needed, so you can include the goals or patient-reported outcomes, etc. And I think we will see also in the future more coordination between NOMS and the ICF. So this is what it looks like when you participate in NOMS and sign into the national database. And this just shows you how you can customize a data report. So I'm not going to, this isn't a how-to, so I'm not going to go into detail, but you can see that you can pick your facility and you can pick what period of time you want to report and then customize it. And again, this is pulling real-time data. And this slide just shows you an example of the comparison of national data to your facility-specific data. So you can see, for example, the number of patients in each of those samples and the scores, etc. So it's very nice, again, to show A, your boss, B, any higher-ups in administration like vice presidents, and certainly regulatory agencies and accrediting bodies, how you can have this information about your facility. It's pretty easy to get started with NOMS if you're interested. Maybe I've gotten you excited about it and you want to participate. First, you'd want to gain the support of your administration and talk with them about the value of participating in NOMS. And certainly ASHA staff members can answer questions and provide more information for you about how to do that. And then you submit your registration information and a letter of agreement and complete some NOMS user training, because of course we'd want to know, for example, that what I score as a 3 on memory in Kentucky is what you score as a 3 in your area. So there's some inter-rater reliability there. And then you start submitting data, and then you can start getting your data back. All right, so now we've gotten a primer on efficacy and efficiency and effectiveness and ASHA NOMS. Let's finish by using some case examples for outcomes and efficacy data. So what we'll do is present the problem that a speech-language pathologist is facing. We'll talk about the kinds of data that might help address the problem, and then I'll give you some suggestions on ways that you might find the data that you need. So here's our first case. This is in a hospital, and this was the question that was posed. Hey, do we really need the speech-language pathology department? So this hospital administrator, as many are, is under a lot of pressure to reduce costs. So each department is being challenged to determine the extent to which they contribute to the mission of the hospital. So the administrator said to each department director, what value do you add? Why do we need your department? Or Maybe they even just say, do we need it to be as big as it is? What is your value added? So the speech language pathology department met to discuss this, and as you can imagine, the initial reaction of the staff, they were offended. They're like, well, how do they not know how valuable we are? How do they not understand what we do for the facility and for their patients? So after that initial reaction, the director kind of reined him in and said, okay, now, I absolutely understand, but let's talk about value added. And in value added, the concept is that it is part of the process, part of the mission that's so valuable that if you asked a patient, they'd be willing to write a check for it. That's the way I like to think about it, because a lot of things we do, a patient's going to say, well, I don't really care about that part. What is it that's so important that's value added to them? So the team talked about it, and they came up with two main things they wanted to investigate. They said, you know what, our patients get better. We're pretty sure that. We'd like to show that during the short stay in an acute care hospital, they get better. We also think that we prevent comorbidities and readmissions. So they took the first one, and they said, let's see if we can prove that our patients improve during their stay. So what kind of data are they going to need? This is a great example of outcomes data. So how are they going to get the data they need? Well, if they participate in NOMS, they could pull up data like this. So this is an example based on those functional communication measures. This is from acute inpatients, and on the left you see swallowing FCM, and on the right the memory FCM. So your teal color is no progress, the light blue is one level of progress, and the navy gray dark color is multiple levels. So approximately 60% of patients move one or more levels in a very short stay in acute care on just these two example FCMs. Now, this is looking at dysphagia and the discharge destination where we send the patients. So this is the percent of patients who were tube-fed dependent when they came in, which means they were a level 1 or 2, and what percent of them go home. So, for example, those patients who are still at a level 3 when they go home, 18% got to go home versus, for example, skilled nursing. But you can see when you move to the far right, a far higher percentage. So if we get the patients swallowing up to a 6, a far higher percentage get to go home. Sending patients home saves the healthcare system money. Home is the least expensive place for a patient to go. There's a nice fact sheet about acute care services in NOMS that you can get off the website. And if you don't participate in NOMS, you can get a national report, but please note the date on that report. So the national data is embargoed for 5 years. And why would that be done? It's to encourage you to participate in NOMS so that the data you're submitting is current and we have a larger volume of current data. But you can get this national report if your facility doesn't yet participate. And there are national reports for other settings as well. So it's not just acute inpatient. You can pull off these 5-year reports for other healthcare settings. All right, now, they also wanted to look at the comorbidities and the readmissions. So they have a very active dysphagia program, and they think that patients who are admitted with pneumonia might really have aspiration pneumonia. They want to find that out, and they think if the patient is discharged without being seen, they might be readmitted. Now, they're going to need efficacy data for this. So let me point out something really cool on ASHA's website called ASHA's Evidence Maps. So you can go to this and select your area, like adult dysphagia, and then you can drill down. So you can drill down by population. It'll gray out the filters. For example, here you can see that it's grayed out everything but acquired brain injury, dementia, and stroke, an unspecified population. So I can drill down to say, you know what, I want to know about screening in these populations. Then you can scroll through all the articles, and it'll even show you what kind of article. So this one happens to be a systematic review. It will rate it for you. It'll do the level of evidence rating for you and explain that. So somebody's done a lot of hard work for us, which is nice. And then you can read the details of the article, and you can go right to the article if you want to read it yourself, which we would hope you would. You can also, of course, get efficacy data from other sources. So they did some research and pulled some other articles about pneumonia and screening. So they've used both outcomes and efficacy data, but they could add economic data if they wanted to, so they could find out the cost of readmissions and add that to their argument. All right, 2 other quick cases. Let's say you work with an outpatient that has been making nice progress, but the insurance company has limited the number of visits that you can have. So how are you going to get more visits for your child that you're seeing? So a few basic facts about insurance. You know, insurance companies limit these benefits on purpose, and they have policies that limit who they're going to cover. So the reality is it's going to be tough to get more visits, but why not use data? So this is the functional progress by the amount of treatment, and notice that it's been drilled down to preschool children with Down syndrome. And you can see by the green bars that the more treatment toward the right of the screen, more children, a larger percentage, make progress. There are some nice fact sheets as well for preschool from the pre-K NOMS that you could download too to use with your advocacy efforts with the insurance companies. And you also can get the 5-year report on national NOMS data. This is just a mention of the pros that I talked about earlier. This just happens to be on the pre-K NOMS and talks about parents' response to treatment. All right, last case, waiting list. You guys are booked solid. There's 15 patients on the waiting list. You stay late to chart, and you know something's got to give. The physicians aren't happy because their patients can't get in. So you meet with the rehab manager, and you say, we need an FTE. We got a whole caseload here we're waiting on that we could have somebody pick up. She reminds you that there's a freeze on hiring. So they first list all the things they believe, all the ways they currently operate. Like, we see everybody twice a week. We evaluate you in the order you come in. We should never give you a break in treatment. And we should never chart during treatment. So they said, you know what? There might be data to answer some of these questions. So they said, what about this twice a week, hour-long sessions? Does everybody benefit from that? Is there a better treatment model? So NOMS data, they took a look at this for NOMS data, and they found that for individuals with mild, moderate disorders, really that doesn't necessarily make a difference. But if you look at those with moderate to severe disorders, then the percentage of patients improving is increased with longer visits. So they might change their treatment schedule to accommodate different disorders and severity levels. Do you have to evaluate everybody in order? Gosh, is there a problem maybe if you delay in evaluation on a particular type of patient versus maybe somebody with an acute onset needs to be seen sooner? And interestingly, the NOMS data showed that urgency matters on everything except voice and fluency. So here is the delay in treatment. At the bottom of each bar, you see how long since onset, and then how much progress is made. Doesn't really seem to make a difference. But with spoken language expression, absolutely. The longer you wait, the less percentage makes progress. And then they looked at the delay between evaluation and treatment. Is there any change in outcome? And we really don't have that information from NOMS. Then they looked at no breaks in therapy. Maybe it wouldn't hurt to have a client have a break in therapy, but we don't have any NOMS data on that in the healthcare setting either. And they challenged their final assumption of, gosh, we don't want to chart during the treatment session. We need to pay attention to the client. Well, there's really no NOMS data for that, but I would encourage you to challenge your own assumption and instead try to chart with the patient and engage the patient in the charting. So let's finish with just a few other challenges. I'm sure you face these, we all do. Productivity, what treatment method should I use? Is my workflow efficient? Are speech pathologists in other settings like mine facing similar challenges? There's lots of other data information in the ASHA website for you. So you can look at the healthcare survey. We'll answer lots of questions for you about others in your work setting, like caseload and productivity demands. You can look on the practice portal, which has tons of information and is a great place to go for clinical information. If you're not a member of a special interest group, which celebrated 25 years in existence this year, there are great newsletters that are more like mini journals that have great information. You can belong to a community and phone a friend, so you can post a question on one of the community pages and almost instantly get feedback from colleagues around the country. So, in summary, not all problems can be solved with data. We looked at some that we don't have data for. But you know what? We need to at least start by finding any data that's available. This is a quote from a new colleague of mine in the outcomes department. He's a master black belt. I'm a lowly green belt. And he says, let the data set change your mindset. Or you could change it to say, let the data set confirm your mindset. But get a data set to see what you're working with. And just to say that ASHA has many resources to help us get the data we need to practice more effectively and efficiently. This presentation addresses facets of one of ASHA's 8 strategic objectives. Objective number 1, expand data available for quality improvement and demonstration of value. You can learn more about this objective and the other 7 strategic objectives by going to the webpage noted at the bottom of this site. Thank you for watching, and I hope I've motivated you to go and seek some data to advocate for you and your department and your clients. Thank you.